Drug developers, investors, researchers, and corporate executives wrestle weekly to understand what is happening in commercial development of NASH medications. Join hepatology researcher and key opinion leader Stephen Harrison, patient advocate Donna Cryer, liver wellness advocate Louise Campbell, and forecasting and pricing guru Roger Green as they discuss the issues affecting the evolving NASH market from their own unique perspectives on the Surfing the NASH Tsunami podcast.
For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up. Episode 40 of Surfing the NASH Tsunami starts now. They say life begins at 40. Some literary folks do. Interestingly enough, this is not only episode 40, it's also the week we passed 4,000 downloads on Buzzsprout, which means an average of about 160 listeners per episode since we cut over. Other podcast data suggests that despite the fact that NAFLD might be a narrow topic compared to a lot of what's on podcasts these days, we rank around the top sixth of 30-day downloads in the entire Buzzsprout system. So thank you to everybody for staying engaged. That's a result that's better than we'd expected. Right now, Louise is with us, and our good friends Ian Rowe and Jörn Schattenberg are with us. Stephen says he'll be here in about 5 minutes. In the meantime, why don't we all get started? Standard icebreaker, one good thing that happened this week, personal or professional.
It's time for Christmas, and I've actually done a tree. So that makes me feel towards the Christmas spirit. Slightly early, but not as early as some.
Excellent.
Well, thanks for having me back, Roger. From a personal perspective, I'd like to join with you the experience from my morning ride. Just this morning, I had a crisp white layer over the entire fields next to the streets, and it felt like winter has really arrived here in Germany, and that was very pleasant and enjoyable drive to work. Professionally, I'm happy that we haven't been overwhelmed by this pandemic at this point. Things are definitely tough still, but everybody has become accustomed to a certain extent, and they're keeping up the good work, nurses and doctors alike, and I think it's a good way moving forward.
After last week's episode, it's timely to say that cases for COVID have fallen in our hospital and are falling regionally. And a sort of personal highlight related to that is that we've developed some models to predict hospital admissions a week ahead of where we are now. And those are now being used regionally. And it's really exciting to do something that has almost immediate impact. Often in research, it takes quite a long time to get from concept of idea to implementation, whereas this has happened over the period of just a couple of weeks, which has been very exciting and only slightly terrifying when you look at the numbers that might be coming.
Fantastic, and congratulations. On a personal note, I made it to Texas in one piece. We picked the timing and date of our flights that we thought it would be time when we see nobody in the airports. And in fact, as luck would have it, it was the one period, middle of the day Tuesday, when there was nobody in the airport. So we were able to get through that part of it pretty cleanly. Now we're sequestered with the immediate family in Texas until Wednesday, which is the next day we're confident we'll be in good shape, and then we'll fly back and we'll be in quarantine for 14 days. I think I gave you the professional best already, the 40 episodes, the 4,000 Buzzsprout, and I think that'll do. Stephen has not joined us yet, but we can get started anyway. This week, we're going to look at an important issue in considering the downstream social impact and cost of NAFLD and NASH. It's linked to cardiovascular disease, CVD. It's been believed and reported widely CVD is the leading cause of death for patients experiencing NAFLD. But as we discussed in our episode 24, when Jörn was actually with us, a paper presented at EASL from Dr. Yunusi's group, Innova, turned the entire issue on its head by arguing that liver disease, not CVD, was the leading cause of death for people with NAFLD. In fact, if you took every cause of death that looked like it might be CVD and you added them together, you got to 15%. I think the liver disease number was somewhere in the mid-40s, maybe 45. The data for that analysis came from a complete set of death certificates issued in the U.S. in 2017, which sounds like a fairly airtight and robust data source. And the group at Innova is one of the most highly rated programs in the world in terms of producing outcomes, health economic, quality of life data around liver disease. That result was striking enough that both Stephen and I commented at the end of that episode that the paper might have been the single most important thing to come out of EASL. And talking afterwards, Jörn made the comment that it made sense to him, seemed to align with what we've seen in some of the key clinical trials in NASH, I think specifically mentioning Stellar 3 and 4. And that's right, there did not look like there was a whole bunch of CVD death in that study. So we had Ian on a couple of weeks later to talk about something completely different. While we were chatting, we learned that he'd done some of his own analysis on the same data set and wound up in a somewhat different place. Now, before we dive in, one note, I was not able to arrange for an author of the paper or anyone else from Innova to participate today. We'll be happy to schedule another session on topic in January. It seems appropriate to do so. But with all that said, so Ian, what did you learn about the sample that might have put the study in a different light.
So thanks, Roger. This is a very interesting and really quite provocative study that was presented, and it raised a number of questions, as you say, about the importance of cardiovascular disease versus liver disease related deaths in patients who have NAFLD. And to try and understand that, I was keen to go back to the original data. And one of the beauties of modern society is a lot of information is produced centrally for researchers to access, and these death certificate data are available for anybody to download, and with the necessary technical skill you can extract the information. But to interpret it, you have to understand where they've come from. And if you consider patients who've only died, then it misses the much larger denominator of patients who are still alive with fatty liver disease. And it also allows the chance to try and understand what the proportion of people with fatty liver is on their death certificate. And when you do that, you see that the proportion of all deaths where fatty liver is mentioned is really quite low. And in the estimate that I made on the analysis that I did, it was at 3%. And if we were to say that conservatively in an older population, the prevalence of NAFLD would be 20 to 25%, then you'd expect that a similar proportion of people who died in that year would have NAFLD, meaning that there were 17 to 22% of people who died with NAFLD, but where it wasn't recorded on the death certificates. And that puts you in a very different perspective, because it suggests then that, in fact, the majority of people with NAFLD are not dying of liver-related causes, and they're much more likely to be dying from other extrahepatic causes.
I think you're making some very important points. And to me, by looking at the data and trying to understand and dive in a little deeper, isn't the central aspect of this disease awareness, like we do see it in many other areas too? The question is, what was coded as a cause of death, and potentially what wasn't coded as a comorbidity? So I think this is one thing that's very crucial to these type of analyses when we talk. And going forward, I think more awareness will hopefully arise from this, and we're going to see more depth in terms of data related to the prevalence.
So first of all, let me welcome Stephen, who arrived about the time that Ian started talking. Stephen, good afternoon and welcome.
Yeah, hey guys, good to be here.
You heard basically the entire substance of the conversation. Ian's was the first substantive comment about what he found when he looked at the death certificate data, and then you heard what Jörn had to say. So kind of hoping we can take multiple pieces of data and get them all into a single frame, right? Jörn, the historical belief in the many studies that link NAFLD to CVD, what we saw in that study, the idea that there is not a ton of CVD maybe in some of the F3 and F4 stages in some of the existing trials, if that's correct. And then, in fact, the low rate of comorbidity, which, as you point out, Jörn, may have to do with what people are looking for or asking about at those moments. How do we start to get a single understanding of the relationship between NAFLD, CVD, out of all that?
I think it's a very valid way they did it to look at associations of coded disease. But the point I was trying to make is I think the awareness is so low that whoever's the doctor that fills the death certificate doesn't necessarily record all required means. I have to say this would probably be realistic for Germany, so no physician would capture NAFLD on the death certificate. It might be a different story in the US and for more some automated aspects, but I think undercoding is a major aspect here.
NAFLD's not going to rise to the top of anybody's list necessarily unless they're a specialist, like a hepatologist filling out their death certificate. In that case, you may have a keenly aware individual that would know to put fatty liver down. But in the U.S. also, a lot of this is done by hospitalists, not necessarily outpatient primary care docs. So hospitalists, typically don't put down fatty liver necessarily. They're going to put down, why the patient died right in front of them, respiratory failure, heart failure, something like that.
So that's it. So that's interesting. One of the things that strikes me as I'm listening is that one of the papers we looked at from the recent conference was about differences in mortality between lean, overweight, and obese NASH. The idea being that the mortality rate was a little faster or higher in the early years in lean, but that was with lower levels of comorbidity. I would assume that a lot of the cardiovascular disease and death that takes place in NAFLD patients does not take place after they get to F3. Might, but they've got enough comorbidities and things going on that it might be earlier than that. which would mean, going back to Stephen's comment, that a hospitalist is going to see those people who will be overweight or obese, who will have multiple metabolic syndrome conditions, and are dying from something related to metabolic syndrome, and they just don't know about NAFLD, and they'd have no reason to think about it. Does that kind of line up with what you're saying, Stephen?
Yeah, I think so. At this point, we all kind of agree there's a pretty standard top three for the reasons people don't do well in fatty liver, or why they succumb in the setting of fatty liver. And different studies have kind of been ordered a different way, but at the end of the day, they still kind of all are in the top. And I think, it is what it is. I would argue that it's not going to be dependent on the degree of fibrosis in the liver, right? Atherosclerotic coronary artery disease is marching onward regardless of the stage of the liver disease. Now, they potentially are linked. And then there's other diseases, right? Stiff right ventricle, right-sided heart failure, these things that we see more often in obese, diabetic, fatty liver patients. That's the whole conundrum with the PPAR gamma agonism, right, that we talk about. I'll come back to this in a minute, but I was just pulling up the Stellar 3-4 paper that we published in Journal of Hepatology, and I think it was July of 2020, just kind of getting after some of the long-term follow-up for these patients. And in fact, cardiac death was not very common. I want to say it was a small number, like just a few cardiac events even occurred in these two studies, which had roughly 1,600 patients with either F3 or F4 disease. So, that may be worthy of a little bit of a discussion.
From my perspective, I think Ian and Jörn and that are quite correct, that it's about awareness. We know that we don't look for fatty liver disease in our cardiometabolic patients in endocrinology and cardiology currently. But I think if I'm right, this was purely death certificate. There were no post-mortems carried out on these patients that was published. Was that right?
That's my recollection.
So we're not going to be able to tease out that sort of information unless it was gone back to for who did and didn't have a PM to sort of look for fatty liver disease. And we know now that more and more data is coming out post-COVID of people actually looking for fatty liver disease in the patients who've had COVID, because we don't look for it automatically despite all of the comorbid conditions that would suggest a high prevalence. And funny enough, when we're looking for it, we're finding that it's driving severity, that up to 9 out of 10 patients in ITU have NAFLD. So there is more and more data coming out on that. And I think the one thing that struck me at the EASL digital conference was a paper I think that I commented on, which was done on the Sunday, which was Kathleen Corey. And they happened to be looking at NAFLD cardiovascular risk in the PROMISE study and had nearly 4,000 liver scans out of 10,000 patients. And what they came out with was simple steatosis on baseline was associated with a 70% increased risk of a major adverse cardiovascular event. And that's a cardiac study that's still waiting finalization and publication. So again, that wasn't F3 or F4. That was just basic baseline hepatic steatosis and a significant risk. So yeah, I think Stephen's right. I think we'll find that it's not necessarily the fibrosis in cardiovascular disease, but just having fatty liver can drive that side.
Thanks, Louise. Well stated. I'm wondering, I took Stephen's question. Stephen, I took your question to be, if we're not seeing cardiovascular death in F3 and F4, then what are we to infer from that?
So I think there's a couple of issues that we're sort of talking around that probably warrant a bit of detailed analysis. The first is around Louise's point about the association between coronary heart disease and NAFLD, and there's no doubt that there is an association there. The importance of that really comes in two different ways. There's a mechanistic association that does deserve some attention because it might open the way to additional or novel therapeutics. But then there's the importance of the clinical association. And, we manage patients who are at risk of having cardiovascular disease-related events in a risk-based way. So we manage their hypertension knowing that we will reduce the population's risk of events, not necessarily that individual's risk of events. And we manage cholesterol by giving lipid-lowering therapy or statins to patients who, depending on where you are in the world, are between 5% 10-year risk of event to 10% 10-year risk of event. Understanding how liver disease plays into that risk assessment will be important, because if we can show that knowing that the patient has got NAFLD meaningfully impacts on the cardiovascular risk assessment, then it becomes really important, because then you should diagnose the NAFLD, because it will change the way that you manage the patient. Conversely, if you have a treatment for patients with liver disease with NAFLD that also reduces their cardiovascular risk, then that becomes an important decision-making point in terms of treating the patient. The first time I appeared on the podcast, that this is, it's about treating the patient, not just the NASH. And thinking about those two different approaches to this association and the sort of problem that we see is important. The other thing that I think is relevant is this apparent low incidence of cardiovascular events in the STELLAR trials is an interesting observation. But if you take the sort of average risk patient from those trials, they're probably at a 10 to 15% 10-year risk of developing a cardiovascular event. And so over the lifetime of those studies, which was a year, you've got 1,600 patients, then, that would be about, 16 to 20 patients in the study. And it's highly likely that patients with significant cardiovascular disease, and those at the highest risk of events, are likely to be screened out by investigators in any case. And there's a reason why primary prevention studies in cardiovascular disease include tens of thousands of patients. And that's because they recognize that, the rates of events are still relatively low. So I don't think we can infer very much from the STELLAR program, although it does provide a sort of interesting observation point and probably sort of pushing off point rather than the definitive observation.
Yeah, and I think your point is well taken. When we think about CV outcome trials, in addition to a large number of patients being enrolled, significantly higher than what we would typically see in even a NASH phase 3 trial. If you look at how those patients are selected based on inclusion and exclusion criteria, it's very interesting. The observation as we begin to design trials in NASH with an eye towards CV outcomes, and we've begun to do this. It's interesting how we select the most at-risk patients for heart disease to enroll into the trials. And what I mean by that is we super select for people with a previous history of an MI, stroke, or outcome. We add into that the presence of diabetes usually, or some evidence of insulin resistance. Then we add in renal failure or significant renal disease, because that's the group that's at the highest risk for having a second event. And so in NASH trials that don't look for CV outcomes, that are designed around a histopathologic endpoint, we distinctly eliminate people with significant baseline heart disease. Now, they could have had an MI in the past or have had some sort of CV outcome, but it, in the eye of the beholder or in the eye of the investigator, is not considered to be significant or not expected to impact the trial. And then on top of that, most of them have normal renal function as defined by a GFR either greater than 90 or at worst case greater than 60. So we basically are selecting for people that are unlikely to have a cardiac event, at least within the span of the time that we're in the study. Now, for a phase 2, it's usually a year, sometimes less, sometimes more. For a phase 3, we plan for a 3-4 usually, and that would involve somewhere between 4 to 6 years. So, yeah, I agree. We're not really selecting people with a high probability of having a risk for a CV event, at least in the time frame of the trial. And for the STELLAR 3 and 4 trials, those were halted prior to having, the patients in there for more than a 2-year time period.
So, Stephen, I think what you've said is really fascinating because it highlights the difference in the way that patients with cardiovascular disease are assessed and managed and the way that we are assessing and managing patients who've got liver disease. So we wrote a piece in Nature Reviews at the beginning of last year about diagnosis of NAFLD and it carrying important prognostic information. And we drew a comparison with patients who are at risk of having cardiovascular disease and said that diagnosing, simple steatosis without fibrosis is a bit like diagnosing a patient with atherosclerosis, which we simply don't do because it's not useful. And the way that the cardiovascular trials are designed, as you just said, are you pick the patients who are at highest risk of having events and treat them according to their risk, and understand that a relatively small risk reduction at the population scale will lead to population benefit. Whereas in liver disease, we've really gone in almost not quite the opposite direction, but in quite a different direction in picking people who, in the sort of short to medium term, are really at quite low risk of events and trying to prevent or reverse disease, where we haven't got to the cirrhotic population yet, really. Although there have been some attempts in the studies to treat those patients, we've not really got a handle on what's going to be required there. Whereas in cardiovascular disease, they start at secondary prevention because they recognise that's where the greatest need is. And I'd be interested to hear your thoughts about how the fields have developed and why they've developed in really quite different directions.
I think from a hepatology perspective, we have wanted to get a drug across the finish line for NASH as a primary goal, right? For years, we've repurposed drugs like pioglitazone and orlistat and Rosi and losartan and simvastatin and metformin and urso and everything else for NASH. And then finally, we get a path to approval laid out by the FDA. Hep C gets, treated. We have a way to essentially cure 99% of patients, if not more. And now we're shifting towards NASH. And really the idea was, let's get something that can reverse the histopathologic disease that we see. And you can call it myopic if you want, but it really was, let's target this liver disease because that's what we do for a living. And in so doing, by targeting the liver disease, do we have extrahepatic implications that are far-reaching beyond the liver? If you view the liver as an organ that generates lots of cytokines and proteins that propitiate other disease processes, such as atherosclerotic coronary artery disease, right? It's not laying down plaque. Plaque being laid down in a coronary artery isn't itself a bad thing. It's when it becomes unstable and ruptures. And so is liver disease generating almost like a cytokine storm, if you will, that causes plaque to become unstable? Is there a link there? And that's never been, to my knowledge, proven. But I think as we've matured as a field, we've begun to say, okay, there's more to this thing than just fixing the liver disease. These people are dying of heart attacks and strokes and cancers. Why don't we try to target something that is more pleiotropic, that can have more far-reaching implications? This is why we get excited about drugs that improve insulin signaling, because we know from the trials that are out there that insulin levels are actually linked to CV outcomes, and that if we can lower insulin levels, there's lower risk of a CV outcome. Same thing with lipo-A and ApoB and modulating atherogenic lipids. And are there drugs in our pipeline for NASH that actually have those extrahepatic effects, if you will? So I think we're beginning to broaden our aperture. In fact, this week there's a big meeting, the CVCT Congress, where we bring together, experts in obesity, endocrine, cardiology, and hepatology, and we actually have a dialogue about this with the agency, the FDA, present. And that'll be for NASH, that'll be Thursday. And this will be a discussion. So I think we started a little myopic, maybe just out of trying to get the ball rolling. And I think that aperture is beginning to widen a bit now that we realize it's not all about a histological endpoint. It's also about the person as a whole. And I just want to circle back to the Stellar 3 and 4 papers because I pulled it up and I just want to get, I guess, the panel's take on what we found. I wanted to be specific in what the findings were. So when we focus on cardiovascular events during a median follow-up of 15.8 months, 16 patients, or 1% in the two studies, had a total of 18 major adverse cardiac events, or MACE events. There was no difference observed between treatment groups. That makes sense. 2 patients with bridging fibrosis and 14 patients with cirrhosis had events, including 5 with a stroke, 6 with coronary revascularization, 4 with an MI, 2 hospitalized for cardiac failure, and 1 with unstable angina. The overall incidence of a first MACE event was 0.72 per 100 person years of follow-up. But interestingly, it was significantly higher in cirrhotics than those with bridging fibrosis. And that difference persisted after adjustment for age and diabetes status, with their hazard ratio for F4 versus F3 for 5.96. So that's what we have, at least based on 1,600 people followed for a median of 16 months, understanding that a lot of these people the high-risk patients would be excluded at baseline because of what we've already talked about with the inclusion-exclusion criteria.
Yeah, that's fascinating. Again, Stephen, that data, the rate, I didn't remember that rate. You actually have 16 events in the cirrhotics and only 2 in the F3 population. And how could we explain this? I mean, sometimes we do even see the changes in the liver go back fat once the liver is cirrhotic. How does the cirrhotic liver link to more severe cardiovascular outcome?
Well, intuitively, you would think cirrhotics are older, but you adjust for age, it doesn't matter. You adjust for diabetes status, it doesn't matter. So I think there's nuances of this that we're still trying to sort out. What Jörn said was it was surprising to him that only 2 patients with bridging fibrosis, but 14 patients with cirrhosis had events that span the spectrum of CV outcomes, right? Stroke, coronary revascularization, MI, hospitalization for cardiac failure, and unstable angina. And trying to parse out why that is a little confusing, particularly knowing that it wasn't because of age. And
like you, the first thing I thought was that those patients would be older and probably with worse other features of the metabolic syndrome. And I guess that we know there are other factors other than age and diabetes that are critically important in cardiovascular disease events, and that's been one of the criticisms that there's always been around the disease association studies, that those factors are not always completely adjusted for. So LDL cholesterol being the probably cause, or indeed in coronary heart disease, but also systolic blood pressure and other risk factors. So it would be interesting to see those, but I think the association with advanced liver disease is clear, and I think we see that in our patients when they come for assessment for transplantation.
I was just going to ask a couple of things. I think obviously it would be interesting to know those F4s as to what their FibroScan scores were and whether or not we're talking about congestion and cardiac congestion due to high scores, because I think certainly in my real life experience, the higher the kilopascals, the more associated disease conditions you tend to see, not dissimilar to HCC occurrence at 25, 35, 45 kilopascals. You tend to see a few more comorbid conditions as you differentiate up the sort of scale. But my other question was probably coming at it from a reverse angle, is how much screening do they do in cardiovascular studies to screen for fatty liver disease? And is it robust, or is it purely absence of abnormal liver function means that there's absence of liver disease, which we know is poor as a screen out for liver disease in any disease state? So what would be the expected liver disease sort of incidence in severe cardiac studies, for example?
So I think that's a really interesting question, Louise, and it's something that we tried to look at, although it's a total nightmare to do. So if you look at the cardiovascular outcomes studies for the new diabetic agents, so like liraglutide, semaglutide, and the gliflozins, then the restrictions that were placed on the entry criteria between those studies are quite different. Some of them have ALT abnormalities as exclusions. Some of them have no exclusions. So the trials that were run by Novo Nordisk didn't have any real liver disease exclusions. And you can look at the incidence of liver-related events in those studies if you have got a willing research fellow to browse through the tens of thousands of pages of clinical study reports that are associated with them. And what's interesting is we've talked about the incidence of coronary heart disease in patients enrolled in the STELLAR program, but if you do the same sort of analysis in the in those patients with diabetes who've got established coronary heart disease, many of whom we would expect to have significant liver disease in addition, there are very, very few liver events in those studies, a handful. And I think that is interesting because it speaks to the relative incidence of, cardiovascular disease and liver disease related events in patients who've got bad metabolic syndrome with diabetes and complications. And that sort of brings us right back to where we were when we were talking about the death certificate analysis at the beginning.
Stephen, just a question. In the STELLAR work that you were talking about, you said that cirrhosis predominated even if you stripped out other factors. Which were the other factors, or how broadly were factors stripped out of that?
Well, it was only adjusted for age and diabetes. So,
okay, those are two good ones. But the question behind my question was this: if you think about all this in a systems theory perspective, a system can lose enough stability over time that an event that in a reasonably stable system wouldn't matter, in an unstable system would. For example, unstable angina is the easy one that comes to mind, or cardiac revascularization, because those are somewhat symptomatic, with the need for revascularization or the presence of the angina. I wonder if the overall systemic fragility caused by being cirrhotic might make the system less tolerable to stimuli or events in other places that would then get more of a reaction. I don't know enough about how the pieces go together. But if all we checked for was age and diabetes, then I wonder if that's a place to look.
I guess a piece of that argument to me would make sense if we were surmising that the comorbid conditions of a cirrhotic patient put them at higher risk of a CV outcome. And to me, that would be more around heart failure or something like that, not necessarily an MI or coronary revascularization or even a stroke for that matter. Yes, it occurred more frequently in cirrhotics than non-cirrhotics, but I can't really tease apart why that's occurring. Maybe if it were all heart failure, I could buy it, but I don't know how an F3 patient has less coronary revascular events than a non-cirrhotic or than a cirrhotic. Maybe it's simply a matter of numbers. As Ian alluded to at the beginning, there was only 800, quote unquote, 800 cirrhotics, not 8,000 cirrhotics, and not 8,000 F3 patients. And maybe those numbers would have washed out had you put a zero behind them. I don't know.
Well, and if they hadn't washed out, they would have taken greater definition, right? So one way or another, I think sample size, you're right, is an issue here. This is why cardiovascular studies are so much bigger. So what do we do with this knowledge in terms of how we educate other hepatologists, educate other physicians, rethink research?
This is where the tough part begins, because we're hepatologists, and I think Vlad made that point at one point, and the patients on the podcast, of course, cried out and said, well, there's a whole patient, but we're best in managing the liver disease, and it'll be difficult to educate from a hepatologist perspective on the best management of the cardiovascular disease. So while there is a clear link, and I think that has been shown in the epidemiological studies, we can see some emerging cardiovascular disease, and I think Ian and Stephen made good points. I still think we have to be focused to really address fibrosis stage or NASH resolution as something we give them recommendations on, and we want to take care of in the future. So I think there is a good reason why we should be focused on that, and that's difficult enough.
Fair point. Other thoughts?
I think I've returned to that thought about knowing whether the patient has NAFLD or not impacts on their cardiovascular risk assessment. And I think, rather than further association studies, what we really need is a very as big as we can with good phenotyping of patients, a study that really answers that question definitively. It may be possible with more time to do that in the UK Biobank data set, where there's where there's going to be a lot of imaging data, and eventually there'll be sufficient long-term follow-up, I think, to answer that question, and we may have to wait for that as the optimum place to find out. Because if it does meaningfully impact on cardiovascular risk assessment, then that changes quite a lot of how we think about the liver disease, because it will be a driver to diagnose NAFLD regardless of disease stage. And as hepatologists, then we'll have to be really very good at risk stratification so that our clinics aren't completely overwhelmed with patients.
So here's a question for you guys. So let's say we're designing a trial with a drug that lowers insulin levels or lowers lipo-Lp or ApoB, and in theory should have a benefit on CV outcome. But when you design a phase 3 trial, how would you do it if you want to try to answer both? And I've had this discussion with the FDA before, and one of the regulators brought up an interesting point. It said, look, it doesn't matter how you die, liver disease or heart disease. If you're dead, it doesn't matter what the status of your liver disease is. In other words, if we design trials just for a liver disease outcome, right, which is kind of the way we currently do it, which is after we get Subpart H approval, we keep the patients in the study. We drive towards progression to cirrhosis, liver decompensation, MELDs from less than 12 to greater than 15, or death. Those are the endpoints we look at. We don't include liver cancer in there, and we don't have any CV outcomes in there. Would it be reasonable to include CV outcomes, particularly if your drug is one that potentially could mitigate a CV outcome? And if you were to say yes to that, would you restrict the criteria at baseline to include not only NASH with fibrosis, particularly F2 to 4, or maybe F3 and 4, and build in some criteria to include patients at higher risk for CV outcomes? In other words, aim for a lower GFR. Include people that have had a CV event in the past 6 months. I mean, what do you think?
Interesting, Stephen. The ways the studies are done is that they aim to get conditional approval at month 12 or 18 for an improvement of the surrogate liver histology, currently potentially a non-invasive test in the future. Then continuing on the study, trying to predict cardiovascular disease, you could probably do that using some of those risk scores that have been published. I think Framingham allows you for a 5-year risk score, but to predict cardiovascular risk in the nearer future is difficult. And then you have to go down the line. You mentioned GFR, previous cardiovascular event, but these patients are facing different aspects. I don't think you should enroll them in a NASH trial. They have to be managed optimally by their cardiologist. They need stents and intensive lipid-lowering therapies, PKCS9 inhibitors, these type of things. So this will make your trial a lot more complicated, I think.
I think that's absolutely right. It certainly would make it more complicated. And the population that you enroll probably depends on what you think that their absolute risk of events is going to be and how they're counted. So if I enroll a population that's enriched for cardiovascular risk factors, let's say they have a 10-year risk of cardiovascular event of 20%, it's quite difficult to enroll a stable population with liver disease who have such a high risk of mortality. And the question with your drug that you've proposed that has metabolic benefits, do you use the surrogates for improvements in fibrosis or improvements in disease activity, knowing that your drug might benefit patients when their liver disease isn't improving? And that becomes a much more challenging commercial problem, because then you're committing yourself to a typical sort of new drug in diabetes cardiovascular outcomes trial. You're saying, we're committing upfront to a big study of, 4,000 or 5,000 people for a period of at least 3 years to accrue sufficient clinical events. And when I say clinical events, I wouldn't include progression to cirrhosis as a clinical event, because, the parallels with MACE are that those are real clinical events requiring hospitalization. You'd have to have a very big study to do that. And it would mean, as I say, that I think that you could, you'd almost become agnostic to a liver disease benefit if you thought your drug was going to prevent mortality from other causes too.
And that's exactly why the CV outcome trials don't look for cirrhosis.
Yeah, because they don't need to, because, ultimately it remains outside of our practices, it remains a relatively uncommon event in the long-term natural history of patients with diabetes.
And the other flip side to that is, let's say you design a trial like this, and in the first year when you're still under Subpart H, you have 20 cardiac events. Now you're going to get flagged as potentially having a drug that's linked to adverse cardiac events. I'm just agreeing it's not easy to design these trials to address that question. I think more simply, an answer might be, can we allow CV outcomes to happen?
So I guess my answer is, to summarize this, focus on the liver endpoint and do an extension and capture all events, particularly cardiovascular. Do this well and have a mechanism in place that you don't miss those. And I think then look for benefits if you have a drug that affects lipids on top of resolution of steatohepatitis and fibrosis regression.
If we look at the PROMISE study, if simple baseline hepatic steatosis infers a 70% increased risk of a major cardiac event in a cardiac study, should it be something we're looking for? And Stephen's trial, is that more reflective of the average person in the street? And should we be directing clinical studies at the majority, not the minority that we select with criteria? So I can see huge benefits to something that, like Stephen suggests. It sounds more reflective of the everyday population and patients. And going back to what Donna said, once you're dead, you're dead. And I would want patients to be managed holistically, not just organ-centric at times, but I understand why we do that.
The commercial challenges are huge, right? I mean, we've hit on most of the major ones, but every time that something happens, good or bad, that isn't about the liver, it makes it that much harder to figure out what the result means, or to figure out how you're going to promote to it or comment on it upon getting approval. And the other thing is that you need huge trials, which are doable in diabetes, where everybody knows the size of the market is vast. Less doable right now in things like hypertension because the market is generic, and there's a completely unproven size of what the NASH market is. So that would be, I think, a really hard trial to get anybody to finance right now. On one level, what we're saying is that reality is complex, but ideally drug trials should be simple, or at least focused on a simple endpoint. That takes me back to Ian's comment about UK Biobank maybe being the place to look. In the States, well, we looked at Framingham for cardiovascular. Framingham wasn't designed to be anybody's drug trial. It was sponsored by the government to understand broad issues around the health and population cohort. That's probably where this kind of knowledge comes from, but then it takes time to benefit treatment, particularly in a place like NASH where getting drugs approved and fully understood is really challenging. So we've now taken an hour to basically get to a place to summarize that goes, it's probable that that one study or data set, when fully analyzed, might not suggest that cardiovascular disease is the major cause of death in NAFLD because of issues around who the population was and how the results were captured. That said, to figure out how to prove the case out one way or another in a commercially viable way will be exceptionally challenging. If I summarized it correctly, where does that leave us for Donna, who isn't here, but would have said, if I'm dead, I'm dead? Where does that leave the patients?
I think in clinics, it'll leave the patients with the best possible care they can get. We're discussing clinical trials here, and I think that's why it's so important to differentiate the outcomes and define the outcome and get one drug or compound to the finish line and then move on with that and see what else it can do. But I think the first steps hasn't been taken in the field, and that's the most next important one.
Other thoughts?
I agree with Jörn's comments.
I think they're fair too, and I was very encouraged by the studies that were reported at the recent AASLD meeting. It was good to see those, and I think we'll have a much clearer idea of what a therapy in NASH is actually going to be able to achieve as those studies that are in phase 3 now come to their maturity. I still think it's very early to be able to understand what the benefits of treatment will be on clinically meaningful events, not just progression to cirrhosis, but, decompensation events, HCC and overall death in those studies when they're mature. And as things stand at the moment, it's good care of the patient, addressing risk factors and supporting people as best we can as hepatologists to, undertake lifestyle intervention and encouraging them to, seek appropriate support from colleagues in primary care with management of cardiovascular risk factors and diabetes.
For me, it comes back to upstream education. We know, and we've discussed again, that these conditions are linked. So finding them early and preventing the deterioration of a condition that we can avoid with education and early location, again, brings us to reducing the pool of patients that we eventually see to the right patients, because we can help some get off the timeline. But personally, I'd also like to see FibroScan now, or some form of liver assessment, non-invasive, in all cardiac studies to tease out the fatty liver patients in them and to look at their reactions to these studies, the same way that an ECG is compulsory in all of our studies. So develop more liver non-invasive assessments in all of the comorbid conditions. And that's the one thing I would say that the FDA should be looking at. If they're all linked, we should have liver outcome measurements in all of these studies.
And with that, Louise, you do have the last word. So moving to wrap up, the one thing you heard or thought about that you found most surprising or most powerful? Brave one first.
So this is Jörn. I'm going to start out, and I think we at length discussed that the connection between liver and heart is real. It's important for the patient. But if I look into those epidemiological studies, the coding of NAFLD is still dramatically under-recognized, I think, overall. And I think moving forward, I want to do this trial where I do assess the patient with my favorite liver test and then see what comes out of it at all stages of liver disease because I think it's important to understand that moving forward. And I think we're seeing some first studies emerge that will be able to answer some of those questions.
Great, Jörn. Thank you very much.
I think Stephen's example trial and trying to understand how to unpick the different aspects of, the patient with metabolic syndrome, diabetes, at risk of heart disease and liver disease, trying to unpick how a trial like that could be designed and really understanding the relative importance of those endpoints for individuals is a really thought-provoking idea, and one that I've certainly spent some time on in the coming days, I'm sure.
I was actually going to echo exactly what Ian's just said, in that trying to tease out all of those aspects is not going to be easy, probably extremely worthwhile, particularly if we were a patient with those comorbid conditions.
Yeah, I agree with all that. I wonder if there is a message here for pharma, and that would be understanding the complexities of unwinding how a patient dies is challenging. So if we can't do that, can we at least focus on the disease for which we're developing the drug? And if your drug potentially has pleiotropic effects that exceed what's happening in the liver, do a follow-on trial in those patients. The THR beta drugs, some of the FGF21s that hit beta-klotho FGF1, 2, and 3C that knock out lipolysis, that improve beta oxidation, that drive down de novo lipogenesis, ultimately have a keen effect on lipids. So you've got 21s that can do it, you've got THR betas that can do it, you've got pan-PPARs that can drive down insulin resistance and also do the same empiric things on fatty acid lipolysis. So get your drug approved for a liver indication, you're generating revenue that way, do a larger follow-on trial for CV outcomes or all-cause death and see what happens.
Stephen, I think that's great. And what I found myself thinking as I've been listening to everybody wrap up is that we're starting to sound like every major chronic disease drug class in development that I can think of. People get indicated for the one thing that's most obvious, and then folks go to school on what else do we have to learn here. GLP-1s are first studied just because they drop HbA1c, and then that's what they have to do to get approved, and then we start studying everything else around that. Ditto SGLT2s. If you go back to hypertension in the 80s, things would get approved for hypertension and then go on to other indications, and then go on to other indications. So I think the tip of the spear question, where's the fastest place to get to market, is question number one. I completely agree with that. And then the issue becomes, how quickly can you expeditiously start to expand out? Can you plan your phase 3 trial with an understanding of where you think you're going to go next if you get the result you expect? Not so that you overreach, but so that maybe you answer a few questions that make it easier to get there. I don't know. This is what I do for a living. It's what you guys do. But it strikes me that an awful lot of market development in the other, as I say, chronic diseases makes a lot more sense, having listened to this conversation about how you would deal with this problem. I think that's been fantastic and fascinating. And with that, we will wrap up episode 40 and move on. Thanks, Ian, Jörn. You guys are always at the ready and have really fantastic things to say, and Louise and Stephen, who are here every week and always have fantastic things to say. And thank you to the people who put this together, to Mike Wilson and to Eric Rounds and to Politelli and Buzzsprout. And mostly thanks to all you folks, the listeners, who've made this such a thing worth doing and who give us feedback on a fairly regular basis about how important and helpful it is. Next week, my expectation is that we're going to be back with an episode called How Did the Liver Fare in the 2020 U.S. Election? That will not be an effort to talk about Trump or to talk about the impact on the democratic system or the recounts or any of that stuff. It's going to be to talk about how the nature of the dialogue and the priorities of the diverse winners will shape things like how science is discussed, how medicines get funded, whether liver will be able to get a louder place at the table given that it might have otherwise. Issues like that are really substantive. And if people have thoughts about that in advance, please send notes or go to the discussion boards, because I'm just throwing it out there and I don't know what it's going to look like, but I would love to get other folks' feedback without getting into invective about either political party or any major candidate in his own right. So with that, let's get through another week. Pandemic is growing, but everybody stay safe. Take care of yourselves. And Sir Pham, we'll see you on the podcast. Have a good week. Bye-bye now.
Drug developers, investors, researchers, and corporate executives wrestle weekly to understand what is happening in commercial development of NASH medications. Join hepatology researcher and key opinion leader Stephen Harrison, patient advocate Donna Cryer, liver wellness advocate Louise Campbell, and forecasting and pricing guru Roger Green as they discuss the issues affecting the evolving NASH market from their own unique perspectives. on the Surfing the NASH Tsunami podcast.